Hi, everyone. I am Craig Escudé. Glad you're with us here again today for this IDD Perspectives webinar. Our webinar today is on top medication concerns in people with intellectual and developmental disabilities. And I have one of my favorite people here as a guest today, Nanette Wrobel, which I'm sure many of you know. She'll introduce herself in just a second, but just as a matter of a quick introduction for me, I'm Craig Escudé. I'm a family physician. I am a fellow of the American Academy of Family Physicians and of the American Academy of Developmental Medicine and of the American Association of Intellectual and Developmental Disabilities. I practice in this field, the field of healthcare for people with IDD for 20 plus years clinically, and now work as president of Intellectability, where we provide tools and develop trainings like the one you have today, the one you're here for today, to help supporters of people with intellectual and developmental disabilities better recognize health risks and to know what to do to mitigate those health risks and improve overall health and wellness for people with IDD. I'm going to turn it over to Nanette and let her say hello and introduce herself, and then we'll get started with the heavy part of the talk here.
Oh, thank you, Craig, so much. So I'm happy to be here. Welcome, whether you this is good morning to you or good afternoon. I'm pleased to present today. I love presenting with Craig as well, and I think that this is something that is right up my alley because, as you can see from my bio, I do a lot of speaking and I do a lot of education on a variety of subjects. I have worked in the IDD field for over 40 years. And I think that allows me to see a perspective of where we've been in the past and where we could be in the future. And hopefully some of that insight translates out to some good clinical pearls that we're going to try and get through today. So
thanks, Nanette.
Back to you, Craig.
I always like to start with a quote from the guest. And Nanette, you were a guest on the IDD Health Matters podcast a while back. And this was something that you said, and I'd love for you to expound upon it a little bit more. Stop looking at the written word, look at the person.
So,
what does that
Craig,
mean?
Yeah, that really came out when I first started in this field. You know, I was in my young 20s and a brand new pharmacist. And of course, you think at that time when you're in your 20s that you know everything. And somebody takes a look at you and says, you know what, you haven't lived enough to know everything. And that person happened to be a nurse who was working in the field. And typical pharmacists come into a facility to review charts, and they may open up the healthcare record and they start reviewing medications. She came over, flipped the book closed, and she said, Nanette, the best advice I can give you is to stop looking at the written words, get up and look at the person, and you'll get a better insight into who they are, what they're doing, and some of the challenges they may have. So I've kind of carried that through my career, and it's really been helpful to me, and hopefully it will be helpful to you as well.
I love that, and that is something that I really learned as well too. Sometimes you're much better served by sitting there quietly with someone and observing them and interacting with them to help figure out what might actually be happening. So thanks for sharing those insights. So let's jump into medications and medication concerns in people with intellectual and developmental disabilities. And the first slide we have here is all about polypharmacy. So I'm going to turn it over to you, Nanette, okay, to tell us about it.
So I think, Craig, for yourself, you and I have talked about this, but as well as for the audience. I mean, we have a lot of individuals who are on today, and regardless of where you work in the healthcare team, I think what you'll find is that this is one of the major concerns that we have. You know, when I first started in this field, again, early 20s, the individuals, one, weren't living very long. They did not have a lot of medical issues. They were on maybe 1, 2, or 3 medications. Today, that is simply not the case. Our individuals are living long, fulfilling lives. They have many disease states. They have many medications. The average individual takes about 14 to 15 medications. And that actually surpasses what we consider to be the most vulnerable population, which is our aged. So if you are working in this field, you know that our individuals are very complex. And so polypharmacy really is, by definition, is the use of many medications concurrently. So if you think to yourself when you're either helping pass medications or reviewing your individuals, the risks are going to increase as we do two things: as we increase the disease states that we're working with, as we increase the medications that they're taking. So we have to look at what other coexisting conditions they have. Do they have cognitive issues? Do they have seizures, which is so common? Also common in our group is behavioral challenges. Do they have GI issues, sleep issues, cardiac issues? All of those things play a role. I am certainly not saying that we don't want to treat them, but we want to treat them appropriately. And unfortunately, it becomes very complicated because our typical individual is not their own advocate. So they may not even be able to verbalize how they're feeling. They may not be able to verbalize what's going on with them. We have to put the puzzle together to figure that out. And as a caregiver, that's why paying attention to the individual, not necessarily what the book says or what their chart says, but paying attention to the individual is really important. Unfortunately, what does happen is we do try and treat every disease state, and we have this prescribing pattern that says we want to care for them as best as we can. Unfortunately, if we can't denote what the side effect may be that they are having, we can unfortunately look at that particular side effect as maybe that's a symptom of some new disease state. And of course, what's going to happen then is we add additional medications on. So that's a problem for our individuals, as well as the fact that if you just look at the coexisting conditions, a lot of those conditions set our individuals up for things like increased falls or increased hospitalizations, maybe cognitive issues because they're cognitively blunting. So when we look to the next slide, Craig, we're going to see some of the other challenges that we might have with polypharmacy.
Yeah, before you go on, I just want to make a quick comment. It seems like I remember a statistic where if you're on 5 medicines or more, your chance of some sort of drug-drug interaction is nearing 100%.
Yes.
Is that about right?
Yes. So anywhere between 5 and 9 medications, and our individuals, of course, surpass that as well.
Yes.
You have a 100% chance of a drug interaction. Now, hopefully, it may be a minor one. But unless you know every drug interaction out there, you're not going to know whether it's minor or whether it is more severe. So that's a really good point. We've got to look at our individuals as they are set up to have drug interaction issues.
Definitely.
Okay, so increased side effect risk, we've already talked about that. They're taking medications, whether that's for seizures or for instance, cardiac drugs or something else. Antidepressants, anti-anxiety agents, antipsychotics may cause some cognitive decline as well. But really due to the quantity of the meds that they're taking, it's really hard when you look at that handful of meds to pinpoint which one is causing one or more of the side effects. And on top of this, I will say, we don't have a 22-year-old that we're living with any longer that we're trying to help. We have individuals whose average age is somewhere in their late 40s, maybe biologically they are in their late 40s, but their bodies may age differently and they may be in their late 50s or 60s. More of our aging population puts them at a risk as well. And then we also have an increased risk in adverse drug interactions because we have more and more antipsychotics or psychotropic meds. We have 36 anti-seizure medications today. We have the use of other drugs, which we're going to talk about a little later, like our anticholinergic drugs, our drying drugs, that can cause adverse drug reactions in this group as well.
Yeah, and there are so many things. It's like I want to jump on so many of these topics, but we don't have enough time to cover them in detail. But Nanette and I do talk sometimes together on many of these drugs and common medical conditions in people with IDD and how drugs can affect them specifically. So look for some more of those in the future. But let's go on to strategies that can help decrease potential issues related to polypharmacy.
And Craig, I will say just before we even start here, you bring up a really good point. Many times when we go to a physician and say the physician diagnoses with hyperlipidemia, the discussion that you would have might be, you know what, I understand I have hyperlipidemia, but I'm going to do some things up front. Let me see if I can change my diet. Let me
Hmm.
see if I can exercise more. Let me see whether I can, use appropriate foods as a mechanism to lower my hyperlipidemia. Our individuals don't get that opportunity to do that. So we
You're right.
immediately put them on a drug. So one of the things that we can use to strategize in maybe helping decrease polypharmacy issues is to do a regular review. And certainly we have consultant pharmacists that come in if we have individuals living in an intermediate care facility, but anybody on that multidisciplinary team can do that. Now, I'm not suggesting that if you're a direct support personnel that you put on your clinical hat necessarily, but what you can do is report anything new that you see. So somebody gets started on a new drug, and the important piece that you have is the observation and the reporting to those that can maybe affect a change. And then anytime a new medication is added, but the other important piece is anytime a new medication is stopped, what happens then? And then we call this process de-prescribing, which is really, of course, quite the opposite of getting a new prescription. We want to see whether we can take somebody off their medications that maybe are redundant. Are they on 3 or 4 medications to treat constipation when maybe a more appropriate one or add a different dosage might help? And then we have two other tools that I just wanted to put out there. One of them is called the Beers criteria. The other one is called the start-stop mechanism that we can have that is also an example of a guideline. And this these guidelines really are used to evaluate, especially our elderly individuals, but anybody can go through this evaluation. You can actually look up online Beers criteria, or you can look up stop-start guidelines, and it will say to you, these are medication classes that maybe we should avoid. So in your spare time, pull it up once in a while. Take a look at it. Take a look at some of the meds that they're recommending.
Again, so many good points. One of them I want to stress is, being observant anytime there's a change in a person's medication. Having all staff be aware, hey, we just started this new medication. Really pay attention to changes in behavior, changes in levels of alertness, changes in levels of activity, changes in eating, all of these things, because a slight change in the person's behavior or desire to eat or whatever, it could be a sign that this medication is having some negative effect that needs to be addressed. So all staff play a role in helping identify potential drug interactions or unwanted side effects. So let's talk about adverse drug interactions and side effects, speaking of those.
Okay, so again, I go back to the fact that these individuals are at a higher risk simply because they may not be able to communicate in the same ways that we communicate. And that communication, as you know, is key. We all get frustrated when somebody doesn't communicate well with us, because having that knowledge kind of puts us in a situation of power that we can then make a decision based on our own healthcare. And we don't have that necessarily with our individuals. So here, communication difficulties, maybe the misattribution of their symptoms. So is the potential for more falls because now it's a side effect of a medication, or are they having blood pressure issues? Or is it because, for instance, they are dizzy because they are dehydrated? All of those kinds of things may be some concerns, but they can't verbalize necessarily that. Behavior manifestations, adverse drug reactions. If you had something in your system that caused you a lot of itching and your skin felt like it was your ants crawling on it, how would you manifest that to the person you're trying to communicate with if you can't say those words? So behaviorally, many of our individuals act out. And then they may have increased sensitivity to drugs that affect our brain, and they may have different types of reactions that we call paradoxical reactions, unexplained, stranger reactions than what we would predict. And that may be due to the fact that they do not have the same number of functioning neurons in their brain. Now, some of these unreported symptoms also are because we don't recognize them as symptoms. So, we've all known our individuals who act out in ways that maybe they've done for a long period of time, and we've attributed it to, well, they've always done that. But is that movement that, for instance, or that picking at their skin, is that something because they are something on the skin that is irritating them? Is it because they're trying to communicate to us, for instance, that they have some negative side effect to a medication? Or is it a precursor to a seizure oncoming? All of these things can occur at any time.
And just to drive home one of the points you made about behaviors and being a sign of a side effect of a medication, let's say you were prescribed a medicine that caused you to feel nauseated or upset your stomach. You may not feel like eating, you may not want to eat, but you will most likely tell someone, wow, this medicine is causing me to be nauseated. But what you might see in a person who can't tell you that verbally is a resistance to eating, or maybe even aggression around meal times. So think about how those behaviors could be a sign of some sort of drug-drug interaction among other types of medical conditions. All right, let's look at strategies to mitigate adverse drug reactions.
Okay, so close monitoring of the physical and behavior changes, especially as Craig said, after a medication change. And to really encourage the caregivers to report even subtle changes. Nothing that they're telling, the healthcare provider is stupid or crazy or is not important. So whatever you observe, make sure that you communicate that. And then, at a higher level, maybe doing some lab values. How are their livers functioning? They're getting older. How are their kidneys functioning? They're getting older. Maybe that is causing some adverse drug reactions as well.
Yep, definitely. So let's look at some challenges that you're going to touch on here in psychotropic medication use.
Okay, so one of the first things I'm going to say is we have tried over the years to decrease the use of our psychotropic medications. We have been totally unsuccessful. So the use of antipsychotics is increasing, antidepressants, anti-anxiety meds, sleep medications, etc. We certainly want to make sure that we're not using them for behavioral suppression. So we are using them for an exact, defined rationale, and not just to mitigate some unwanted behavior. And then we need to make sure that we realize some of these medications can cause some serious side effects. We learned that with our antipsychotics. Some of the ones that came out on the market in the 1980s, 1990s caused a great deal of weight gain, caused diabetes, metabolic syndrome. We're always concerned about our antipsychotics and movement disorders, like tardive dyskinesia is one of them that we can recall, but it's basically a late playing out movement disorder that even if we take them off the medication may not go away. And then we have a high prevalence also of off-label usages. So we all probably have come across a situation where an antipsychotic may be used as a sleep medication. Well, that's probably the most expensive sleep medication and puts the person at risk. And so, Craig, you wanted to make a comment about that as well.
Yeah, and I would say here about some of these long-term side effects. As you mentioned earlier, Nanette, in the beginning, people with intellectual disabilities are living longer, which means that they're going to potentially experience these long-term side effects of weight gain and diabetes and hyperlipidemia and things that some of these medications can cause. So we need to be really aware of all of the side effects, including the long-term side effects that will be more likely to come into play. So one of the things let's just talk about medication reviews.
Yes. So medications can be in place for years and years and years, and we all know that. Once a physician writes a medication, unless we're really careful about reviewing it on a continual basis, it may be, well, they've always been on that. Maybe it is a missed opportunity for de-prescribing because nobody's really looked at that information before. And then documentation issues causing prescribers to inherit either an individual or a list of medications that they themselves did not prescribe. If I had an individual and they were seeing in the past a cardiologist, and the cardiologist put them on a medication, maybe as a medical physician, I might not be I might be reluctant to make a change in that medication.
I was going to say that because that
like
happens. Someone comes in on some medications and I am a little reluctant. It's like, wait, do they need this? Do they not? I need to observe them for a while. But the point you're making is perfect, is we really do need to look at it and say, does this person really need to be on this medication? And can we try tapering it off, lowering a dose and see what happens?
Good point. And then, like you said before, the cumulative side effects risk over time because they are on these medications for a long period of time.
Yep. Dosage and administration issues.
Okay, so, our individuals are unique, just like we are. And, if we have medications, and we've got at least a couple of them out there now that are definitely weight-based dosing or age-based dosing. You might learn that if you look up Beer's criteria or the stop-start criteria. You'll see that there are outlines on what dosages we should use. And, dosing errors can occur. Swallowing difficulties. If we have medications that are difficult to swallow for our individuals, and that difficulty swallowing may be ingrained in that individual. It may also be because of other medications that they are on that cause them to have difficulty swallowing. And then sensory aversions may lead to refusals. You've talked about that, Craig. So, even though we may want them to take the medication, they may not be in a situation where they find that is something that they want to do.
And swallowing difficulties, or maybe a person doesn't like the taste of the medicine. Sometimes we'll mix it with something. Sometimes we crush pills, and we need to really know, can these medicines be crushed or can they not? Which is another concern I think that we really need to be aware of. If you're crushing a medicine that is not meant to be crushed, the person could get a much higher dose very quickly of that medicine, which would not be a good situation.
And Craig, there are a lot of medications being made today that have alternative ways in which they are absorbed. So that you bring up a very good point.
That's
and
good
then our
know.
caregiver.
Yeah.
We don't do enough of it. You work for a company in which this is your highlight, but there's not enough information out there. You know that. We've talked about you could be doing a training every single day and not reach everybody that you need to reach. So caregivers play a central role, but they may not have that formal training. And then there's also human error in terms of dosing or incorrect dosing, administration time errors. And there may be delayed reporting in terms of an error that took place because you may not discover it for a period of time. So we definitely need to do more training.
Yep. And I'll let you lead the way for the next few slides.
Okay. So one of the things that we also have issue with is informed consent and autonomy. So we know we have an informed consent process, and I'm not suggesting we get rid of this because it's an important process for us. Right. But sometimes we presume that the individual is not capable of working with us in terms of making a consent. So the bias is on part of the guardianship who says, I am the person who's going to make the decision for this individual. Well, maybe we haven't asked them. Now, I am not suggesting that those that are not capable of making a decision, that we should allow them to do so. But certainly there are some that are. And they may be, language difficulties, information may not be there. But in terms of the lack of involvement in decision making, we have to assume that the person has at least partial understanding until we know differently, which will give them the ability to say, you know what? Let me do something else. I don't like the way this sounds, or I don't want to take that medication. Maybe this would be a different medication I could take, or whatever the situation may be.
Yeah, I completely agree. So when
and then transition of care is a big issue. So our individuals, of course, are mobile. They do go to hospitals. They move to group homes. They may be in an ICF. Now we're able to be in a group home, in a residential facility. They go to outpatient cares. Every single time that occurs, there's a potential for making an error in their medication. And that has to do with the breakdown in the communication we may have. Not only in communicating with other caregivers, but in the fact that we've got to have an accurate medication list that follows that individual. Maybe an unintentional discontinuation or a duplication of a medication. We see that happening as well. And then the lack of documentation between caregivers. So we don't spend a lot of time informing the next caregiver what the history of that individual was, why they were on the medications. We send them their possessions and the healthcare record and say, basically, now it's yours. You deal with it.
Yep, you're right. We do definitely need to have a better method of really explaining health risks and helping new supporters or new provider organizations when a person transitions from one place to another to understand all aspects of that person's health and wellness support, including medications and why people are on them. So I love this next slide, so I'm gonna let you jump in on that.
Yes. So, Craig, we could spend all day talking about this, the behavioral versus medical symptom confusion. So medical symptoms can present as behavior changes. How do our individuals tell us that they are in pain or they have an infection? How do they tell us they're constipated? Many times it's agitation, many times it's acting out. And we may not be able to identify that underlying cause. We may not even be thinking that it's a medical cause. So we've got to start thinking there first. And then, if it is a medical cause, you don't want to put that decision off for a period of time. If you're thinking that, well, they're just acting out, or that's the way they've always behaved, or, that's something that they've done in the past, how do they tell you they've got a urinary tract infection? So, if you've ever had one in the past, it can be quite uncomfortable. Maybe they're behaviorally acting out, and that's delaying the necessary medical treatment that they deserve.
Yeah, and I can't stress the importance of this, and it's actually my favorite topic to talk about. We even have an e-learn course built specifically to teach supporters of all levels about the connection between behavioral changes and underlying medical conditions. You can take a look at that on our website. It's called Actions Speak Louder Than Words. So what about access to specialized care?
Okay, so I'll just quickly go through this. I know our time is getting short here, but we don't have enough people like Dr. Craig Escudé.
Oh, you're
Many
too
of you
kind.
who know he trains other physicians in IDD so that they can work in this field with some knowledge base. We don't have enough of that. And we don't have enough of those providers. We don't have enough specialists. Geographically, we have disparities. We may have some in our larger cities, but we don't have some necessarily. I live in Illinois. I live in the Chicagoland area. I have access to a lot of providers. Maybe if you live down south, you don't have as many access. And we all know now the long wait times as seen by practitioners, or even practitioners who just quite honestly say, look, I don't have any skill in working with these individuals, take them someplace else.
Yes, yes, thank you. Boy, you made so many good points, and Nanette, I know you and I could sit here and talk for probably another 2 to 3 hours and on all of these different topics. But this was meant to bring awareness to this particular situation about medications and the complications and the challenges in using them in people with IDD. It's not to say that we should not use medication at all, of course. Many medications have great benefits and are certainly needed, but it's use them judiciously, cautiously, with an understanding of the potential risks versus the benefits for any medication that you prescribe. We have a lot of people that are interested in or posting questions, but we're not going to be able to get to them, unfortunately, or maybe we can stay on a little bit longer. But I want to let everybody know that there are a couple of handouts in the control panel where you can click handouts, and you can download one on polypharmacy concerns in people with intellectual and developmental disabilities. There are also slides. The slides for today's presentation are also available to be downloaded as well. I do want to tell you that we have a number of e-learn courses that teach about multiple medical problems that we see more commonly in people with intellectual and developmental disabilities, and help train staff on how to improve health outcomes. But we also develop custom e-learn courses for states and organizations as well. So if you'd like to learn more information about that, we've done some on medication administration training for states, choking and prevention management, and a number of other topics. And also want to let you know about the Fatal 5 training that we have, which is the top preventable causes of illness and death in people with IDD. And you don't have to, some organizations make this available, or states make this available statewide for supporters. But if you don't have that availability, you can take it right here on our website. And this course, along with most of our other ones, are actually accredited by the National Association of Direct Support Professionals for credit for the e-badge. We definitely want to hear your feedback from today's presentation, and there is a survey link in the chat, or I believe the chat box, the chat section. So please click on that link and tell us what your thoughts are and what you'd like to hear more about in the future. And we take this very, very seriously. And I mentioned earlier that Nanette has been a guest on the IDD Health Matters podcast. I'd love for you to take a listen to the podcast where I talk about or talk with leaders in the field, people with intellectual and developmental disabilities who are self-advocates, nurses, case managers, pharmacists, state developmental disability directors, and many others. So I really appreciate you joining us for this webinar today. I hope that you'll join us again for some other ones, and reach out to us directly with your questions. You can visit us at replacingrisk.com. My email address is simply craig@replacingrisk.com, and you're welcome to email me as well. And Nanette, I want to thank you for being here with us today and taking the time to share this information with everyone.
Thank you for asking me, Craig. And I hope everybody has a wonderful afternoon and great rest of your summer.